Well, welcome to Optometric Education Consultants National Live Webinar Series. Tonight we have Pharmaceutical Update 2021 with Drs. Greg Caldwell and Tracy Offerdahl. Dr. Caldwell is a graduate of the Pennsylvania College of Optometry, where he completed a residency in primary care and ocular disease. He is a fellow of the American Academy of Optometry and a diplomate of the American Board of Optometry, and a fellow of the Optometric Glaucoma Society. He works in a medical practice as a disease consultant in Duncansville and Johnstown. He has lectured extensively throughout the country and other nations. In 2010, he served as the president of the Pennsylvania Optometric Association and was on the board of trustees for the American Optometric Association for 2013 to 2016. And he's president of the Blair Clearfield Association for the Blind. And it's also our great pleasure and an opportunity to have Dr. Tracy Offerdahl, who attended Temple University School of Pharmacy in Philly for both her undergraduate and graduate degree. Once she got her Doctor of Pharmacy degree, she completed a residency at Temple University, where most of her time was spent in internal medicine and infectious diseases. She's currently on faculty at Salus University in the Department of Optometry, where she's course director and instructor for all systemic pharmacology courses for students in the optometric, audiologic, and physician-assisted programs. She's also a practicing clinical pharmacist. As we alluded to earlier, she's also a fellow of the American Academy of Optometry. So with that, it's my great pleasure to welcome Greg and Tracy to do pharmaceutical updates for us. So guys, take it away.
Thanks, Joe. And it's always a pleasure to share the podium. Tracy and I don't know, Trace, 7 years now, maybe it's been going back. It's always a pleasure to share this, to share the stage, or in this case, a virtual stage with you. So thanks for being here tonight.
Ditto. It's my pleasure.
So disclosures here. This one I'm definitely going to take some time on because we're going to be doing pharmaceutical update. You know, the first one says here, you know, this was prepared independently by me and Dr. Offerdahl. The lecture, I have lectured for Alcon, Allergan, Airy, Biotissue, Kala, Maculogics, Optiview. You can see the advisory boards here. I'm going to be spending a lot of time maybe mentioning a lot of the products from these companies and dropping down to the fifth bullet point or sixth bullet point there. I have no financial interest in any of these companies or products. I just want to kind of show you the differences that are out there. I do serve as the PA medical director for Involve. It's a managed Medicaid. I do serve as the chairman of the advisory council for diabetes for the healthcare registries. And the second to the bottom bullet point, the content and format of this course is presented without commercial bias and does not claim any superiority over any commercial product or service here. So that's probably the biggest bullet point that's out there. And I think most of you know that Joe and I are the co-owners of Optometric Education Consultants. Tracy.
I have no financial disclosures to mention. And as Greg mentioned, we also prepared this lecture without any commercial support or interest in mind.
Thank you. So, you know, why Tracy and I started doing this, you know, we always laugh. You know, I think our first one was 2015, Pharmaceutical Update 2015. You can imagine what we did the next year, 16. And here we are now doing 2021. And the reason is every year the FDA approves numerous pharmaceutical or what you see sometimes in state law, legend drugs for the management of diseases and therapeutic categories. So what we try to do is find those that are pertinent to optometric care and discuss them. So this here slide I came up with just to kind of remind everyone, when you come to the pharmaceutical resource matrix, you have your sales team, you have your medical affairs team, which is a medical science liaison. That's usually who I try to, in a sense, hang out with because they're either optometrists or MDs or PharmDs, PhDs. They're the ones that are, in a sense, allowed to talk off label. And they can get down into the granular and talk about adverse events and so on and so forth. So they're not they're two separate silos, the medical affairs team, and then you have your commercial or sales team that, you know, they come in and with all the different regulatory and sanctions that have occurred, you're going to see that they always talk on label. And if you do say, hey, I'm using this, they'll either run out of the office. I'm using it for something off label. They'll run out of the office, or they'll connect you to the medical science liaison. And the reason why I do that is because I know some of my colleagues out there get frustrated when that happens, but you have to realize that, you know, they can only talk on label. They can do the educational lunches, bring you the samples, talk about discount cards. If you ever do want to kind of get granular or talk off label, just ask to be connected to the medical science liaison. And I think a lot of people realize that there's a marketing team, a research, clinical research team, and then market access. Tracy, you want to add anything to that before we move on to the next slide?
No, I think you hit everything that needed to be hit.
All right. And then, you know, there's a lot of, I think, maybe some confusion in the market. One of the first products I believe we're going to be talking about today are these loteprednol products. And, you know, a lot of times I'll hear people say, there's enough of those out there, but maybe with some reformulations. A good one would be cyclosporin, right? Cyclosporin is Restasis. Sun comes out with it. And what they did is they changed the concentration, which really doesn't change maybe the mechanism of action in a way. But then they did this, nanomicellular wrapping of the medication, and that changes the mechanism of delivery. So what I want to kind of point out here tonight is that there are mechanism of actions of a medication, and it might seem like it's the same medication, but it's a different in the mechanism of delivery, which can then change how the molecule distributes across the surface of the eye or maybe penetrates. So is there anything, Trace, that you can add or want to kind of go, that's kind of your specialty? Is there anything you want to take a deeper dive of mechanism of action, mechanism of delivery?
Well, it's such a great question, because I would say that other than dermatology, there's no other therapeutic category that has a bigger influence on really efficacy and toxicity, et cetera, than ocular meds. We see such a change in the mechanisms of delivery right now, which ultimately doesn't change the mechanism of action, but it's so important. I was mentioning to you guys before we started the webinar here, I had a primary care doc call me the other day at work and say, I don't understand why this optometrist prescribed Inveltis for this patient. It's loteprednol. There's so many loteprednol formulations out there. And I was explaining to him, I said, well, okay, fair enough. But there are some decisive differences between regular loteprednol and, some of the newer formulations, including the Inveltis with that micro size particles. I think they use the amplified delivery system. And I said, many of these different mechanisms of delivery are very specifically designed to improve upon the mechanism of action to get the job done in terms of, getting better penetration into different areas of the eye. So mechanism of delivery is vitally important in the ocular world. And you'll see some of those products here tonight.
Perfect, thanks. Which leads us perfectly into the first polling question here, which is, regarding the various loteprednol etabinate ophthalmic drops, do we have enough? We have enough formulations. They are all the same to me. Help me with some of the differences. Steroids are steroids. They all do the same thing. Or what we can do, if you want to tonight, I'll have Joe and then I'll try to police the comments here in the chat box. So if you want to put things in the chat box, that would be great. Yeah, looks like people are rolling in here nicely. There we go. I just found the chat box, even though I said I was going to use it. All right, looks like we've got almost a good percentage of people weighing in here. So I think getting loteprednol covered by insurance can be a challenge. I agree with that. All right, I'm going to end the poll. share the results. And you can see, help me with the differences. So Trace, we got our work cut out here for us. We got to talk about some of the differences in some of these loteprednol products here. So when it first comes down, when we're talking about steroids, remember that there's ketones versus esters. And one of the very first things that when I talk about, the ketones is I believe that, and Tracy can help me, I believe the ketones, they need to be broke down some other way, or maybe in the liver as they penetrate, whereas the esters get broken down by plasma cholinesterase is how they get broken down. And the ocular surface has a lot of plasma cholinesterase. So that's why these loteprednol products that are esters, when you use them, they're more for ocular surface conditions. They penetrate into the cornea, don't get a really super high concentration into the anterior chamber. So now you start seeing that decrease down in, see that lower risk or that safety profile increase with decreased IOP pressures and spikes, and then cataract formation. So, Tracy, can you use some of these slides here to maybe talk about, this says here the C20, this ester steroids versus ketones, and, what's the difference there going on?
Well, that's another great question. We say, or I always say regarding drugs, when you think of penicillins, when you think of steroids, when you think of statins for cholesterol, different types of antihypertensives. I could name lists and lists and lists. People always say to me, well, why would I use one versus the other? And most of the time it's something as sophisticated yet simple as this C20 ketone versus a C20 ester, in that while a drug may have the same basic mechanism of action, there are subtle differences that have, many times a very great impact on not so much efficacy, but toxicity. So, and I follow up by saying that if a C20 ketone steroid and a C20 ester steroid were identical, then we would only need one drug in the entire class. We would just be using loteprednol for everybody. There would be no prednisolone. There would be no, dexamethasone, et cetera. So these slight differences in structure, and usually as a side chain in most pharmaceutical classes, make a huge difference in terms of sometimes efficacy, but usually toxicity. And, we learn this over time, and it really benefits the patient. This is just one of those great examples.
And just to be clear out there, as I'm thinking, through this, is that Pred Forte is one of those C20 ketones, along with the FMLs that are out there, right, Trace? Is that,
Yep.
Yeah. So the one that we use the most is Pred Forte, and that would be a ketone versus, loteprednol being an ester, again, being broken down by that plasma cholinesterase. And so, when we come and look at the loteprednol etabinate products that are out there, we started off with Lotimax way back when, has a suspension at 0.5%. And then Alrex came out. And I thought that was a great product to really be launched, because I think we all used steroids at one point to treat allergies, but we never had anything that was on label. So then I think that was a nice, breakthrough in a sense, because at least we had an on-label use to use for allergies. And then Lotimax gel came out at 0.5%. And we're going to talk about Lotimax SM submicron gel here that was recently brought out by B&L. And then Invaltis through Kala came out, and that's the Amplify that Trace talked about. But then just recently, and I have the date coming up, I think it was July of last year, that Isuvis was approved. And the reason why I like and what this one made the cut tonight is because it's really the first product steroid that's approved for dry eye. I think we all use steroids for dry eye, but it was really, in a sense, off label, maybe standard of care because a lot of docs did it. But, it's nice now having a pharmaceutical drop that actually has an indication that's out there for the use of dry eye that's out there. So Tracy, I want to make sure I'm correct on this. We see suspensions. That means they don't need to be shaken, right? Solutions need to be, because they can separate out. Is that how that works? Or suspensions
the
need to be
opposite.
shaken, right?
Yes. So when you think of suspension, you think of some little tiny particles are suspended in a solution. So they need to be shaken in order to suspend the particles and make sure that they're evenly distributed.
So the suspensions need to be shaken, and I did say that backwards, but that's the reason why the gels came out, because
Yeah.
when the gel is there, right? So a lot of people say, well, why is there Lotimax suspension 0.5 needs to be shaken, and you have the gel that doesn't need to be shaken? Is that correct?
Yep. And just as a really quick follow-up comment to that, in looking at these mechanisms of delivery and making sure that, gosh, is a loteprednol suspension as good as a loteprednol gel or a submicron gel, et cetera, et cetera. The FDA is looking very closely at these different formulations with ocular meds, because the actual approval process, particularly of generics, is there are questions that come up in terms of, well, is it going to give as great penetration when you have a generic that's a slightly different formulation? So the solutions, the suspensions, the gels, the emulsions are being evaluated by FDA subgroups to verify the efficacy as well as the penetration in the anterior segment of the eye, et cetera. So you're going to hear a lot more about these going forward here.
And let me just, one of the comments is which drop was approved for dry eye? And it's, and Joe answered it, Isuvis, for those that are out there. Joe, thank you for launching putting the handouts into the chat box for those who just want to download them. So let's jump in here. Let me actually go back. So if you see Lotimax suspension here, 0.5, and then you have Lotimax gel, that's 0.5, and then you see the SM, the submicron. One thing I want to point out is notice right off the bat that the percentage went down, right? So in Trace, I'll have you in a few seconds here talk about, less medication is usually better for the safety profile. But Lotimax SM, meaning submicron, which is the particle size, is indicated for postoperative inflammation and pain following ocular surgery. I think a lot of people want to think that that's just, for cataract surgery, but it can be used really for any surgeries that are out there, and in particularly, LASIK procedures that are being done, and really any ocular surgery. The SM again is submicron. The particular size is reduced to facilitate. Now we're talking about this mechanism of delivery. You're able to get a better ocular penetration, which now allows us to not have to use it 4 times a day versus you can get down to 3 times a day. You can get that increased intraocular penetration, a lot smaller. It diffuses across the eye. It's able to distribute and then penetrate. And you can see there, Lotimax gel, the new 0.3%, you can see that is 0.4 to 0.6 microns. Lotimax gel 0.5% is 3 to 5 microns, right? And if you think about what you can see on an OCT spectral domain can get down to about 5 microns worth of resolution. So Lotimax gel might, on a good scan or very high quality scan, might be able to pick up Lotimax gel because of that 5% micron. But look how much smaller that 0.4 to 0.6 micron with the new 0.38 gel. So with that being said, you can see you have a potential of 10-fold increase in spreading across the eye, and then being able to penetrate and get to the tissues that are out there. The question I have for you, Tracy, is it significant going down 0.5 to 0.3? And then, is using, maybe 1 or 2 drops less a day is, from your end, is that a big deal?
Absolutely. And I would have the same answer for any drug that we were talking about. But I think it's particularly important with the ocular steroids because of, some of the more chronic use of the steroids and the side effects, adverse effects that we would see historically, including, being cataractogenic. So decreasing the concentration and improving the penetration is exactly what you want to see in something like this, basically making the delivery system a little more sexy delivery system, as we like to say. And it certainly will benefit the patient both acutely and chronically.
Yeah. So, I hear docs out there going, oh, it went from 0.5 to 0.38 and 1 less drop. No big deal. Well, it is a big deal.
even just with intraocular pressure.
All right, so let's talk a little bit more about Lotimax SM. We're going to talk about the 0.38% increased concentration demonstrated in ocular tissues within the cornea and within the aqueous humor following a single application installation of Lotimax versus the Lotimax gel. And compared to Lotimax gel, the 0.5%, a single topical installation of the 0.38% were greater in the aqueous humor and in the cornea. So you can see here, just by going to that submicron, that change in mechanism of delivery, in a sense, not really the mechanism of action. It's the same in a sense, maybe molecule, and maybe it does react a little different. Maybe it did change, but you have less medication, or the same medication, in this case, 1 drop compared to 1 drop, and you're getting greater aqueous humor and cornea penetration. And the concentrations in the conjunctiva remained the same, the highest out of the ocular tissues with ample drug and to mediate the anti-inflammatory effects. Now, formulation advancement while maintaining low BAK. BAK, I'm not sure if people realize, for years, we all know the negative part of BAK in a chronic use, chronically used, especially those dry eye products. BAK can really beat up the ocular surface. But back in the day when you had a tough time getting maybe an antibiotic to penetrate, some of the pharmaceutical tricks that are out there, at least that was taught by me to the pharmaceutical companies and the MSLs, was to, jack up that BAK. We know it roughens up, softens up that cornea, and it would allow it to penetrate. So I think being pointed out here is, what B&L wants to kind of show off. And we know the problem with BAK is you're still able to use a very, very low amount of BAK. The lowest amount of concentration, you can see there, 0.203% in this medication versus Inveltis being 0.01%. That's out there. Tracy, any comments on BAK that's out there with the tricks of the trade, or anything you want to say about BAK?
Well, I think you would be surprised to learn how little non-optometrists know about the benzalkonium chloride and, the various preservatives that are available. Not only the good, but also the bad in terms of, how it can affect the ocular surface, et cetera. So, there's a lot of discussion out there. I don't think I never heard about what you just said in terms of the benzalkonium chloride kind of beating up the surface a little bit to increase penetration of an antibiotic. That's like a trade secret, I guess.
Yes, there you go.
Pretty fascinating.
Within the pharmaceutical, ophthalmic pharmaceuticals, right? That's out there. So Lotimax SM, 0.3%. The submicron formulation is designed to reduce the amount that you need to use, of the concentration. Again, that's a big deal. It doesn't seem like a big deal. 0.5 going down to 0.38%. You're able to decrease the frequency. It's a TID drug versus BID. So it's getting into now muco-adhesive. It's non-settling. It's got this shearing, thinning gel. It's a gel, so as soon as it goes into the eye, it just automatically almost becomes a liquid and becomes, in this sense, muco-adhesive upon into the tears. And you don't need to shake it because it's a gel. That's the big thing about it. Suspensions, remember, you got to shake. They separate out like salad dressing. So you have to make sure. And because of this gel and the way it hits the eye and then breaks and then immediately becomes a liquid, it's a non-blurring type of medication that's out there. So let me just check and see if there's anything in the chat box regarding this SM. And Trace, do you have anything to talk about before we move into Inveltis and then moving into the Kala?
Just one other quick mention of a suspension versus a gel or even an ointment. One of the big problems with suspensions is how people shake it or don't shake it. Not shaking it is the worst thing you can do, because essentially at the top of the ocular bottle, the eye drop bottle, you are getting very little of the active ingredient. And as you go down then through the bottle, as you get towards the bottom, you get super concentrated portions of the drug. So suspensions are well known to be problematic in that regard, both from an ophthalmic perspective as well as a systemic perspective. People just, you can put 5 stickers on there in neon yellow that say shake well before use. And, people sometimes just give a little shake, versus a nice, healthy 5 or 10 times. So the fact that you can use a gel that immediately works and doesn't go into an eye blurring type scenario is amazing.
Yeah. So again, moving into something like this now in Veltus, where it is a suspension, good reminder when we do these to remind your patients to shake the bottle. And I'm going to spend very little on this because this really isn't a pharmaceutical update. This was 2018. In Veltus, Kala came out, but I did want to touch on this nanoparticular based mucus penetrating. So their MMP, their amplified technology. Again, another change in the mechanism of delivery, allowing it to penetrate through the mucin. So some of them attach to mucin, and some of them now are just trying to penetrate, in a sense, to treat the dry eye. Now, Inveltis used this amplified technology, but it was, again, you can see the 1% was postoperative inflammation and pain after ocular surgery. It was a BID dosing that was out there. The one I wanted to spend some time on is this one that was approved on October 27th. I think I said July earlier. There's one of these with July that was approved October 27th of last year. I know that my Kala rep was in on January handing me out some samples here. If you remember, it was KPI 121. Everyone was excited about that, and it finally got approved. And now it's Isuvis. And this is the first prescription therapy specifically for the short-term treatment of dry eye disease. So that's what I think is a big deal, is that we now have an on-label. At least you could use whatever you want now within a steroids like we did before, but at least we have a medication that is on label for, in this case, it was approved by the FDA for short-term treatment. And I'll talk about that here in a second. Right there it is, short-term meaning up to 2 weeks. And you're hearing this buzz about, it's used for dry eye flares, and we're going to talk about these flares, these acute exacerbations of dry eye that are out there. The next slide or two. Contraindication warnings. There was really nothing new to report. And I guess that's right, Trace. That's not like an assumption that, just because it's a mechanism of delivery or a change in percentage that we can assume that it's that it's going to perform the same way, right? We always have to be careful even when you change something.
Yep, absolutely.
Yeah. So don't always assume out there that, it's the same medication, lower percentage. Sometimes you get surprised, and that's why they do it. But really nothing new came out of this. The same old standard stuff, delayed wound healing, IOP, cataract, and, watching infections. Adverse reaction, the most common, which was 5% of the time, was pain upon installation. And I always kind of say that's kind of a duh, because, the pH shifts in someone that has dry eye. And so when you put it in, it is going to most likely burn or sting. And that's where that comes from, is from that pH shift that's in here. They did do safety and efficacy. And it's really based on what I thought it was worth putting in here. One of the largest clinical programs in dry eye, an N of 2,871. Typically, when you see like studies done, and some glaucoma studies, they'll make, we're gonna switch to SLT and make it a primary therapy over maybe prostaglandins. And we did a study of N of 50 or an N of 75. Sometimes these N's are pretty small, but this one here is a pretty big N. If you guys look at studies, 2,871. They're called the STRIDE studies. If you want to look them up, there was STRIDE 1, 2, and 3 to bring this to market. And, what are these dry eye flares? You're hearing this buzz. You hear the Isuvis reps running around talking about, look for those flares. Well, it's an onset of inflammation, which is driven. There's a variety of triggers, as you can see down here at the bottom, about 3 bullet points or 2 bullet points up. You can see that seasonal allergies, air conditioner use, digital screen, what we're doing here tonight, air travel, the dehumidified air on an airplane or being circulated, contact lens, smoking, diet, and then different types of medication. And patients just get these flares that are out there, and it's being kind of I guess paralleling to, as you can see down at the bottom, people that have asthma and maybe rheumatoid arthritis, and they're being controlled by certain medications, and then they have to be given a steroid maybe to control their asthma or to control their rheumatoid arthritis or lupus. So these systemic patients that have inflammation, lupus, rheumatoid arthritis, Sjogren's, asthma, they get these breakthroughs where they have to use, maybe like a rescue inhaler, which I don't know, is that a steroid, Tracy? Rescue inhalers? I don't really know. So, or what do they do for asthma or rheumatoid arthritis when they get breakthroughs?
So a rescue inhaler is going to be just a pure sympathomimetic, which causes bronchodilation. Alexa just woke up. So what you would use for maintenance would be a steroid. So that's going to be used daily, usually twice a day, to decrease inflammation, on a daily basis and long term. But the rescue inhalers are always just quick bronchodilators.
Perfect. Thank you. So, some thoughts on dry eye as I was thinking about the Isuvis is that in some of the marketing materials and reviewing from college, that 80% of patients with dry eye disease suffer from flares, and they don't report this to us as optometrists. And I've been using this medication now for 6 months. Like I said, my rep came in and gave me some samples and kind of explained where to use this, and talked to the MSL docs to kind of talk about this a little bit more. And the patients come in and they just think it's kind of normal, and they try and work their way through it. So now we kind of have a drop here that we can use that. And 45% of the patients just have flares without continuous symptoms. And that's really where I'm finding that where this drop works well in practice is that, you can use this on someone that maybe is like our kind of mild immunomodulators, which would be your cyclosporins, which could be the sun product, Sequa, or it could be the Restasis product that's by Allergan. And they're on this continuous therapy. And then they get the breakthrough, and you can add the Isuvis, which is the short term up to 2 weeks, as it says in the package insert. And you can use it anywhere from 1 to 4 times a day. And you just kind of have the patient kind of use it PRN. But where I've been finding this is not on those patients with the Restasis and Xiidra, but these patients that just kind of, I can use some tears, and tears are fine. And I get a little breakthrough. As this is saying here, about 45% of the patient just get flares, and that's really where it's been nice using this medication. This medication, Isuvis, comes in a nice big size bottle, 8.3 milliliters, and I've been using this MedCure pharmacy down in Fort Worth, Texas, which takes care of a lot of the prior authorizations. There's 17. This is what I thought was pretty remarkable. There's 17.2 million United States patients diagnosed with dry eye. There's like 30 million that are out there when you talk about dry eye. There's 30 million people, and 17.2 have been diagnosed. Now, just think about all these commercials. Restasis, I've been seeing for 2 decades. I see the Xiidra commercials, so on and so forth. And when I had to really look at this number and reread it, 75% have never tried a prescription therapy. I thought that was kind of a low number, but that's the number that came out of the study whenever I was reading it. 75%, with all these years of Restasis, and now Sequa that's out there, and Xiidra commercials, the cute little guy, 25% are only on or have tried prescription therapy. And within that, 2.9 have used steroids for dry eye. And then 80% of patients that start a chronic medicine like Restasis or cyclosporin or Xiidra, stop in about 4 months. Anything in there striking you, Trace, before I move on that you want to talk about?
There were 2 quick questions that you alluded to the answer to some extent. One was, how would you write a prescription for Isuvis for a patient with dry eye disease?
Yeah, so it's basically the package insert says, up to 2 weeks. Now, when I prescribe it, I write, 1 drop QID duration 14 days, and I usually give 1 or 2 refills. And then this is after I've already tried to sample, the patient likes it, so on and so forth. And then the nice thing about it is I just say, come back and, depending on where their pressure is, it's either 4 months or 6 months. So I can just do a real quick pressure check on the patients, because that's really the big key that we have to worry about.
And then the other one you mentioned where you were getting your product out of Texas. So someone had a question about prior authorizations. Can you talk about those direct ship pharmacies real quick?
Yeah. And now, this is, from my understanding, I can use your help on this one, Tracy. This is just kind of like your pharmacy that you have that just Kala has been using. And they have some hired support staff to kind of help with those prior authorizations. So it's called MedCure. And it's in Fort Worth, Texas. I just got it from my local rep, who just said, hey, listen, they're going to help the patient out. And if they're commercial, they can get it for like $40. And now they're working with the Medicare patient, and somehow, some way, they're able to get it, I believe, for $60. So I just used them. But when I called down and chatted with them, it just seemed like I was kind of like calling your office rather maybe than they kind of partnered with this office rather than maybe being on some of those direct ship type of pharmacies that's out there.
Gotcha. Yeah, there are a lot of companies that are popping up to interface for the prior authorizations, et cetera. Cover My Meds is the most common. So, interesting. I didn't know that they were doing that for Isuvis. Good to know.
Yeah, good to know, huh? And anything else pop up here in the chat?
One thing just said, given that it's approved for dry eye, is insurance more likely to cover it? I keep prescribing Pred Forte because every time I prescribe loteprednol, it's too expensive for the patients.
Yeah. So, I mean, it's just, I can't, when I do these talks, you got to be careful because there's just all kinds of formularies and changes that are out there, especially when you start doing these national talks. So, that could be something that's kind of regional. Obviously, prednisolone has been around for many years, and then I have no problem using it. I did it for many years. You just have to be a little bit, in a sense, I'm not sure what word I want to use, or just be aware, I guess is probably the best word, that it's got an increase, in safety profile, or decrease in the safety profile. They're most likely going to, develop a pressure spike or, have a little increased risk of cataract. Just monitor them. But if they're, pseudophakic, pseudophakic, then great. And then just watch the pressure on those patients. So.
Yeah, and I'll tell you, from the pharmacy staffing side, I see exactly what this doc was saying too about, the insurance companies fight tooth and nail for anything that seems unique or more expensive than the standards. So loteprednol certainly fits in that category. But I bet that we're going to see better coverage for Isuvis than using some of the other loteprednol products. But the one stipulation may be that, they have to try Restasis or Xiidra first and see what kind of mileage. That's what I'm thinking is going to be kind of the standard. So we'll see.
And Ryan here mentioned, I sometimes see post corneal transplant patients, and that could be full PKPs, that could be a DSEC, that could be a DMEC procedure on chronic Pred Forte and taking an anti-IOP medication, a glaucoma medication because of the steroid. Any thoughts on changing to loteprednol? Sure. A couple thoughts on that. You can go to FML. I think it has a little bit less risk of creating that IOP spike, but also, I could go to a 1% loteprednol on that, and you'd be safe doing that. I do have a corneal specialist. Joe, I know you have a corneal specialist in your practice, and maybe you're, being a neuro guy and a glaucoma guy that's out there. But what does your cornea specialist use for, for the long-term usage of keeping that DSEC or that PKP from rejecting?
Well, I think that he has been using a generic prednisolone.
So there you go. He's still using that. And if you get a pressure spike, I can tell you, I have a corneal specialist comes into my practice. Yeah, as long as my cornea specialist would just basically say, Greg, just please keep them on some type of steroid, usually 1%, something 1% that will stop at the rejection. And Greg, that's what you're there for, to manage those issues of pressure spikes and rejection in a sense. So John, you're certainly okay to switch to a low prednisol if you want to try and do that on there. All right, so let's talk about the mechanism of action. It is that amplified technology, and mucus is a barrier for it's what it's there for, right? It's to protect the eye from things invading the cornea and conjunctiva. So amplify through two ways tries to work around that barrier, getting those particles, those particles, about 500 nanometers, not microns, but nanometers, so nanoparticulars, and then they wrap it in some type of coating so that it doesn't stick to the mucus, it actually slides through the pores. And now what you're getting is that nice distribution and penetration through that mucus barrier. So that's really kind of I guess the scientists that developed it would be like, well, didn't give a lot of thought to that, but sounds kind of simple. But really, to boil it down, they made it really, really tiny to get through the pores, and then they kind of lubed it up so they can slip right through that mucus and get to the tissues that are out there. And that's your mechanism of delivery change with a medication that's called lotopredinol etabinate that's out there. So anything roll in, Tracy or Joe, with the chats, and before we move into the glaucoma medications?
Nope.
Good. Anything you want to say?
One, literally, as you said that, question is, could you use this for RCE as well?
Yeah, I mean, recurrent corneal erosion, that's kind of not my way of, I guess I don't have a high amount of patients using it, but if you're trying to treat the inflammation, absolutely, you could use any of these lotopredinol, even if you wanted to kind of use it off label, to the Isuvis for that patient. So good. Yep. All right, so let's jump into polling question number 2 here. I'll launch it. I have it up here while you were chatting, Trace. I was able to pull it up. Just curious, those who are treating glaucoma out there, have you used Notarsadil, which would be Repressa or Rocklatan, in your treatment of glaucoma? Yes, no, I don't treat glaucoma, or I'll place a comment in the chat box. And while that's happening, I had a few people, if you can put, unless it's really sensitive, I had a few people direct message me. It's hard for me to do this and follow those. Because I have one here, because it penetrates the tissues better, is the higher chance of IOP with 3.8 versus the 0.5? And the answer is no. It's maybe equal or lower. Someone was asking about the lotopredinol 0.5 or because it penetrates. It's not a higher risk for it to cause a pressure spike. That's a good question. I got one here, direct message. I use FML for dry eye patients. How long do you leave patients on low dose steroid? I've been using it for long term with good results, with no IOP or other side effects of steroids. FML, again, is a good one to be using out there. It's, how long, it says, how long do you leave a patient on low dose steroids? You can leave them on, I have some patients that have rheumatoid arthritis or Sjogren's, and they need to have it every day. So 365 days out of the year, as long as it's, not creating a cataract or creating a pressure spike, then it's safe, or creating other, maybe interocular infections. So you can leave them on all year round, depending on the condition. And I think that's it. We're caught up. So here we go. 29% have used Notarsadil, and majority have not, and a few haven't treated glaucoma. That's out there. So I wanted to talk about Repressa, Notarsadil. It's kind of an older drug that's been approved, but doesn't have a lot of usage out there. But really, more importantly, then after Repressa came out, so did Rocklatan, and I wanted to talk about that. And then I just kind of wanted to show you a couple of some of the ocular side effects that are being being reported. So Erie in 2017, so it's, not really much of an update, but it's, Repressa, this was really the first new medication that came out that wasn't a Me Too drug since Zalatan. And Zalatan was my first presentation, 1994, that I did as a resident. So in 1994, latanoprost came out, and then the Me Too drugs all came out. So you can think about Lumigan and Travatan, and then we had Azop, but they were used elsewhere, and you had all these other medications. We really didn't have a new novel medication until 2017, this Notarsadil that came out. And it was working by this, this ROCK-NET inhibitor that was working in the trabecular meshwork, breaking down that actin and myosin, those adhesions that are out there that were really targeting the trabecular meshwork. And really, I just wanted to show you these slides here. And this is no tricks to magnification that's out there. This is trabecular meshwork. That's where the disease of glaucoma is. It's a stiffening. It's an issue with the trabecular meshwork, trying to get the aqueous through into Schlemm's canal, into a collector channel, then into the episcleral venous side. And you can see here that what the medication does is it expands the trabecular meshwork. It really relaxes that actin and myosin. You can see 200 microns and 200 microns really allowing that aqueous to flow through the trabecular meshwork. Now, I just want to have this up here to kind of show you that they did Rocket 1, 2, and 4. They just ran out of time getting people into 3. Wasn't anything bad with it. They just folded into 4. They just didn't have enough people in it. But this is a single agent. And when you do single agent, it gets tested against timolol. It doesn't matter what's out there. Azop got tested against timolol. Latanoprost got tested against timolol. It's an inferiority. And where I want to just point out is, the Notarsadil products, they lower about 4, 5, or 6 millimeters of mercury when they work. There are some failures out there, but it's not like latanoprost, you're going to see this huge drop. But I can tell you where I think the sweet spot is with this medication is that it lowers a low IOP. We all know that if you get someone to come in with a pressure of 32, it usually reacts pretty good, and you can drop it with, say, a prostaglandin analog. 32, I've seen them go to 20. But if you use this medication, 32 might go to 25. But what happens if you have that pressure of 16 and you're just trying to get 1 or 2, points? It's hard to do that with the standard medications that are out there. The Notarsadil products, I've seen people go 16 to, if you get that 5-point lowering, I've seen them go to 11. I've seen them go down to 9. And people are like, well, how can you sometimes see some of these big lowering of pressures? Because one of the mechanism of action, which I didn't talk about on the mechanism of action side, is that it's actually been shown to help lower the episcleral venous side. So there's really a new mechanism of action with this medication. Mechanism of action, really lowering that episcleral venous pressure, expanding that trabecular meshwork. So the Repressa and the Notarsadil at this low percentage, 0.02, can lower a low IOP. Now, it does come with some side effects that are kind of new and popped up. You have some of these conjunctival hemorrhages that are out there, which I think is more venous dilation from that episcleral side, but that's how they classify it as in the package insert as conjunctival hemorrhages. The verticillata that you see with amiodarone is, you could see that with the Notarsadil product that's out there. And it's the same phospholipidosis that you get with these other medications too, like naproxen and chloroquine, amiodarone. It's the same phospholipidosis that you get with Notarsadil. So you kind of get that kind of pigmentary change. Now, I spoke with the medical science liaison because I sent them a couple of pictures. I remember this was my first LOL moment. Here's a patient that I'm using in my practice. I'm treating one eye with a medication, Notarsadil, maybe something else was being used. Up here, I have an amiodarone patient. This is someone that's using amiodarone, kind of getting that classic whirl-like appearance. And I remember seeing this patient, and I pulled a microscope over, and I see all this pigmentary changes, and I'm kind of sitting there going, what the heck is this? And I go over the other eye, I come back, I'm starting to think of all these like crazy conditions, Fabry disease, what could this be? And then I had this little LOL moment, and I'm like, oh, this is the pigmentary changes that they're talking about that can happen with Notarsadil. And they said that they usually see them, as you can see back in their studies here. This is right from their studies, the rocket groups that they did. You could see it kind of has this whirl-like appearance, and they had some up here, maybe not so whirl-like. But what my experience and the patients that I've seen that experience this whirl or this pigment is not this classic appearance up here. So if you see that kind of, I remember then again, I said about the LOL, then I went, duh, I lecture on this. This is the side effect. So I took a picture of it, and we're seeing it here tonight. So don't expect it to kind of be like this true amiodarone appearance that's out there. And Joe, I know you do a lot of glaucoma treatment. Have you seen these pigmentary changes with the Notarsadil?
I've seen a few.
Yeah, and are they kind of the world-like, or are they kind of a little bit more atypical?
It's atypical, kind of smaller.
Yeah, okay. So the summary of the Notarsadil is the conjunctival hyperemia. You have 20% chance, so 1 in 5 patients getting that verticillata that we talked about. 4.7 of them experience, this is talking to the medical science liaison, experience reduced acuity. They said, but however, no clear association why that was, but then they all resolved after 13 weeks of discontinuing the medication. And then we talked about the hemorrhage. So you got the hemorrhage, the hyperemia. I don't think that's any big, it's something new, but it's this verticillata that's out there. Trace, before I talk about this Honeycomb, is there anything you want to add to that Notarsadil product? Is there anything from your end?
No, other than the fact that I have seen a humongous increase in patients taking the Repressa. So it's getting paid for without prior authorization in most of the patients that I've seen. We dispense a lot of it when I'm doing the staffing side.
Okay, good. That's good to know. And then, here's a Honeycomb epithelial edema associated with the Rho kinase inhibition. And I have to give a little shout out to Charles McBride, optometrist in Oregon there. Joe and I are both in the Optometric Glaucoma Society. They do have a Google Groups, and he put this in here. And this is a nice little anterior segment OCT showing kind of this little honeycomb epithelial edema. And then again, talking to the medical science liaison, it's usually in patients that are, in a sense, have some type of like trab surgery, some type of incisional surgery, a little bit beyond IOL surgery, something that's out there, a little bit like maybe someone had a failed trab, or maybe a corneal transplant or something along that line. Really not like cataract, but again, it's incisional surgery, but maybe because it's so micro incision. But I still wouldn't be afraid to use this medication, but there's been this reported honeycomb epithelial edema. And again, I have to give a shout out to Dr. McBride. He said that, I had a patient today with a pressure of 34. I didn't really measure the cornea thickness, took a nice little cool shot of this honeycomb epithelial edema. You can see here, the eye was blind from neovascular glaucoma. So it wasn't your typical eye. And I don't really have any other follow-up other than I wanted to kind of show you the cool OCT or that honeycomb that's been reported. And when I asked Charlie if I could use the slide, he said absolutely. And then Dr. Shovelin said, oh, hey, I have a patient here that had a corneal transplant. You can see a graft patient again. There's that incisional surgery beyond cataract, and use the Repressa, and you can see kind of these little dot or honeycomb again, which discontinued. If you would say could discontinue if it's a graft. So I'm not sure if he discontinued or not, but you could see the honeycomb that occurred.
Hey, Greg, question came in.
Yes.
If you do see corneal changes, should you discontinue the Notarsadil?
I guess it's going to be based on patient by patient. I don't know if there's any long-term effects. The patient that came in of Charlie's that had neovascular glaucoma and it was a blind eye, I'm not sure if there's any long-term effects or if there's going to be any epithelial breakdown. I'm not sure what Dr. Shovelin did on his, if the graft had still some good vision. I think it's going to be based patient by patient. I could ask Charlie what he did, but I'm just going to kind of say if that was my neovascular glaucoma patient, blind eye, and the pressure was high, and I'm just trying to get it down to where it's a comfortable eye, and they had some honeycomb, I would probably leave it on. If the patient had some good acuity, it's probably going to disrupt their acuity, and you'd probably have to discontinue it.
And then about the conjunctival injection, do most of those patients discontinue the drug? It's a pretty high percentage, and the question came in regarding, if people are working in the public eye, so to speak, has it been an issue? Do most of them discontinue the drug, or do you add, a vasoconstrictor?
Yeah, there's a couple different ways that I'm going to answer that. Yes, you can use a vasoconstrictor like Lumify, which is we're going to talk about here kind of shortly with what the adrenergic agonists here, alpha agonists. You could do that. I've had some patients where it was severely bad; they just needed to discontinue it. But my clinical pearl would be try to get them out about 3 or 4 weeks. It seems that if you can get them out to about 3 or 4 weeks, they do peak, kind of get their eye, I think, gets used to it, and then it starts to calm back down. I can tell you that, there's some docs that are in the area that, that are speakers like myself. And in the new slide deck that has come out, that they have actually patient testimonials saying, yeah, my eye is red, but I don't want to go blind. So I guess, talk to the patient and say, hey, I do notice your eye's red. I want to understand that. And this seems to be working. Do you want to stay on it? Because I'm sensitive to it. But I have had some patients that we discontinued because of some really severe hyperemia. And then we had to resort to something else. But yeah, you switch over to Lumify, which is great, right? It's a very low percentage of a glaucoma medication, right? Of like bimatop or brimonidine. So.
Yeah, and you know what? It's such a great question, because if in fact your prediction is correct that it is a vasodilatory issue, then it would make sense that after 3, 4, 5 weeks, that it would start to abate in most patients, because they're sympathetic receptors, and sympathetic receptors tend to sort of downregulate after a period of time. So that would be an interesting anecdotal thing to really, monitor.
Yeah, very cool.
My experience has been that PGA hyperemia can be persistent. It's lower grade, but it tends to persist, whereas the urokinase, it is much more intense, but it dissipates. And my magic number has been 11 days.
There you go.
Interesting. Seems like publishable information, FYI.
Yeah, there you go. So that kind of tees us up for this one. This one's a little closer, right? 2019. And this was Rocklatan. It's basically your first prostaglandin combination. And, I want to point out that you don't see a lot of prostaglandin. It's the only prostaglandin combination in the United States, because remember before I talked about it was an inferiority when it's a single agent. When it comes to combination, it has to be superiority against the two products, against all times. So like if you think about, or if you think about latanoprost and timolol, it works great, but then you don't have that beta activity in the evening. So the timolol is really not helping out in that combination medication. And it always fails in that evening where it doesn't meet superiority. So then it doesn't come to market, because in the superiority testing, it's got to be lower at all time points. And that's why with this medication, putting the Tarsadil and latanoprost, which are the ones that create the most hyperemia, right, into the same bottle, that one was why you got your first prostaglandin combination. I can tell you, it works well. I've got this frustration with it's not being covered by a lot of insurance companies, even though it was March of 2019. But I am the third-party chair for Pennsylvania, and I am working with some of the insurance companies. We just had a big win with Zydra, with UPMC in my area, getting it to tier 2. So, sometimes it's upon ourselves to go and advocate with some of the payers. I have some papers right here of some of these prior authorizations where I'm getting some people with just one bottle using this medication, really, really, really low pressures. And, they're using 3 or 4 bottles to try and get the same lowering. And, it's frustrating because we all know that there's problem with adherence and getting drops in the eye. So, this was approved. It's the first PGA. And, it says refrigeration, and, you can then do normal storage after opening. At least that's for now. And that might change as time goes by. Joe, any comments on Rocklatan, or Trace, any comments on Rocklatan?
The only thing I would add is in terms of what Greg was mentioning for prior auths, et cetera, with the Rocklatan versus single agents. I have 3 Wills eye patients that have significant unilateral glaucoma, and all 3 of them, no connection other than they just happen to be my patients, but all of them are on, one is on 3 different drops, the other's on 4 different drops, Repressa being one of them, and their insurances will not pay for the prostaglandin analog ROCnet inhibitor combo. So they have to do it individually. So the one patient is on 5 actually, and she said, I literally spend my entire day trying to schedule around how I can take these medications.
Yeah. And those are the type of testimonials I think it will help with some of these payers that are out there.
Yeah.
So Durista is a bimatoprost, basically was approved May 23rd last year, 2020 by Allergan. As you can see here, it's an intracameral administration for the reduction of intraocular pressure with open angle or ocular hypertension. It's a sustained release. It's injected into the anterior chamber, biodegradable implant. They had a little bit of probably a setback on the indication, is that the indication is just for one-time use. If you use it, and it has been done by glaucoma docs, if you use a second administration, it's just off-label at that point, and that would just be a call by the doc. This implant has 10, is this micrograms, Trace, MC micrograms of the drug. What I've learned from talking to the MSL is that just ask yourself out there, those who are listening, what is 10 micrograms? Is that like 100 drops? Now this is the 0.03%, not the 0.01% that we use now this was the original Lumigan that they're using. How many drops, ask yourself out there, how many drops are in 10 that's being released over this 3 to 4 month period? And in some of the studies, it's been shown to work out the 12 months. How many drops are in there? And the answer is 1. It's 1 drop that is in there, that's in this biodegradable material that slowly gets released over time. And I did want to spend a little time on the contraindications because, they did change a little bit since you are injecting it. So, obviously active or suspected ocular or periocular infections. Be careful with your patients that have endothelial cell count dystrophy, which would be Fuchs, prior corneal transplant, your DSEC procedures that are out there. Just be careful. And then obviously anyone that's allergic to the bimatoprost. The warnings and precaution, corneal adverse reactions. The bimatoprost implants have been associated with corneal adverse reaction of increased risk of cell loss. You be careful. People have narrow angles because that's where it needs to kind of go down there and sit. People with macular edema. When we use topical, we never really got too concerned about macular edema, but if you're injecting this one in here, you have to be careful with those aphakic patients, those phakic patients with torn capsules, be careful. And then obviously the intraocular infection, the pigmentation, and you're injecting the endophthalmitis, just be aware of those warnings and precautions. And you'll see here again, the dosage, they had, in a sense, probably a little shock when the FDA came out and said, that it's a single intracameral administration of the biodegradable implant. So again, I've seen it done twice in the same eye. It's just off label, and that's just what the surgeon has decided to do. If your Durista rep comes in and starts talking to you about it, they're only going to tell you that it can be only used for a single use. They're working to figure out some of the, that biodegradable material didn't always go away. And that's why the FDA said, nope, it can only be for single, because you didn't want to have all these biodegradable parts that were building up in the anterior chamber. So, back to the drawing board, and that's where we're sitting right now. And you're getting an IOP reduction of 5 to 8 millimeters of mercury, and that was in patients that had a baseline of 24.5. And there were phase 3 studies done on this implant. Where I want to move into now is these adrenergic alpha receptors, and then moving into some maybe what's coming, and then let Trace talk about some of the newer medications. So, Upneek is how this slide came about. I wanted to talk about Upneek, the 0.1% oxymetazoline hydrochloride. But it's not really the first, adrenergic alpha receptor agonist that's out there. Iopidine or apiclonidine, 0.5%, 1%. Then you move to your alpha GANs, and alpha GAN P, 0.2, 0.15, 0.1. Lumify, a very low concentration, 0.025%. Brimonidine tartrate. You have brimonidine tartrate here. I thought it was kind of neat that you get an IOP lowering in meiosis. Here you get no pupil response. It's a redness reducer. And then other adrenergic alpha receptors are your NAFCON, the nafazolaline that's in there, and then you have the A for the antihistamine side. Visine is, we're all familiar with that, the tetrahydrozoline. And then you come out with Upneek, and you have other oxymetazoline type of hydrochloride with nasal sprays and eye drops, and there's actually topical cream for rosacea. All of these are alpha adrenergic. And polling question number 3 is, have you used Upneek in your practice yet? I'm just curious. It's new. It's this year. Have you used it in your practice yet? Trace, any question or anything you want to add to say this here as we're waiting for the polling question to roll in?
Well, I'm just thinking through, sorry, I was chewing a piece of ice. Just thinking through the alpha receptor agonists and how, I always, of course, go right to systemic meds. And when you think of like an alpha receptor agonist and how it fits into the whole sympathetic nervous system, anytime you have an agonist and an alpha receptor, we're going to see vasoconstriction. So that vasoconstriction is occurring locally, in the eye, but also systemically to, depending upon the medication. And just a little pearl, I once years ago tried to get, how if you overuse alpha agonist nasal sprays like Afrin, et cetera, you can get that rhinitis medicamentosa, where you get a downregulation of those sympathetic receptors, and you end up with more stuffy nose than you started with. It takes usually about, a week minimum. Some people, it takes up to a month of using Afrin nasal spray, and all of a sudden the vasoconstriction stops. They get rebound vasocongestion or vasodilation. I also did this with Visine years ago, and it took 32 days before my alpha receptors in the eye switched from vasoconstriction and beautiful white sclera to vasodilation. And it was a nightmare because I literally looked like I'd been sitting in like a marijuana den for the next 3.5 weeks while I discontinued the Visine and let my alpha receptors reset. So it's an interesting conundrum when we're using some of these agents.
Yeah. And that was, I remember back in the day in high school, a lot of my friends kind of, if you want to say addicted, which was not addicted, but it was neosynephrine. I can remember.
Oh yeah. Well, the receptors become addicted. It's crazy. It's not like you're going to lose your job and live on the street because of it, but it causes crazy symptoms.
All right. So polling question number 3, majority, just a handful of our attendees here have used Upneek in the practice. So we're going to chat about it. So, Upneek, it's through Osmotica Pharmaceuticals. Now, in doing this, I realized that, You want to talk to the RVL part of Osmotica because they do have Trigen and Vertical. So there's 3 companies under Osmotica. This is the RVL side. This is the one that was July 9th of last year. And you can see that it's indicated for acquired blepharotosis in adults. It's preservative free. It comes in vials. It does have a nice little soothing, the hypromethylose that's in a lot of tears that's out there. That's part of the delivery system. So if you want to say the warnings and precautions, just be careful. It's an alpha adrenergic agonist. It may impact blood pressure. It's a very low percentage. So I would just say be careful on your patients that are very brittle cardiovascular, orthostatic hypotension patients that are out there. Just be careful with those patients. The adverse effects, 1 to 5%, treated with upneak, had some punctate keratitis, some conjunctival hyperemia, blurred vision, so on and so forth. The drug interactions, they're alpha adrenergic agonists. They may impact blood pressure. Caution in your beta blockers, your anti-hypertensive that are out there. Caution in use of exercise in patients with alpha adrenergic agonists in the cardiovascular diseases or the benign prostate hypertrophy. Trace, with this medication, I've been using it pretty liberally, and you're going to see some examples here. Really, I ask about the high blood pressure. Is this a big concern, you think, on your end, or is it just kind of ended up in the package insert?
Yeah, so fun fact about FDA warnings, if there is a chemical that's going as an ophthalmic medication or a topical steroid on the skin, anything like that, if that chemical has been shown to cause, like oxymetazoline, hypertension when used systemically. Sorry, all the dogs went nuts at once. Then they have to mandatory FDA requirement that it's placed into the package insert for any topical medication, whether it's skin topical or ophthalmic topical. So even though the chances that oxymetazoline are going to increase the blood pressure are slim to none, they are mandatory reporting of the potential side effect because we see it in systemic meds.
There you go. So the mechanism of action, I'm not going to spend a lot of time on this. It's going after right here. You can see the Mueller muscle in raising up, and there's a lot. I'm going to do a little bit more digging. You can see the 5-to-1 ratio and the alpha 2 versus the alpha 1. And that's why you don't really get the pupil change, but you do get the eyelid change in the mechanism of action of using this alpha agonist that's out there. Dosing, 1 drop into the eyes, into the ptotic eye or eyes once a day. You can use it because it will wear off, maybe lasts about 8 hours. The peak effect is 1 hour. As you can see down here at the bottom, it's a once a day to the upper visual field and to what they call the marginal reflex distance. That is what they were able to use to get this to market, is this once daily for the upper visual field and the marginal reflex distance. Again, 1 hour peak onset in the 8 hours of that it lasts. Here are my patients that came in, and this patient came in, and you can see she does have a high lid fold up here in both these eyes. She has ptosis. So I said, "Oh, let me just throw this in your eye, and don't judge the outcome." She was thrilled by this. She loved it. She's using it every single day. And here's the marginal reflex distance. You can see the white light right here. You can see the distance between the white light to her lid margin, the marginal reflex distance. You can see it has, improved, maybe a millimeter, 2 millimeters, 1.5 millimeters. Definitely looks like a little bit more on this side. Again, she's thrilled and using this medication. This patient over here, she had come into the office and she had some contact dermatitis. So I had to fix the contact dermatitis. She was in late phase. I put her on a Medrol dose pack, but then she's telling me, "Doc, I need to get rid of this." I think it was this weekend, June. I have this, this wedding, so on and so forth. And so I cleaned up her with some topical steroids and oral steroid Medrol dose pack. And then I said, this stuff has some decongestion. It's got this oxymetazoline. She wants to raise her eye. Then we were able to use the Upneek after we got her all cleared up on using the Medrol dose pack. And she was thrilled by this. I mean, look how she just kind of lifted her eyelid up and she was all excited to go to the wedding again, which I think was yesterday. And then this patient comes in, and she's in a sense a younger patient here. You could see, I was like, look at your eyelids here, kid. Let me go get a sample of this and put it in. And she was thrilled by how her eyelid came up. So, I probably have an N of 10 that are out there. It's kind of in a sense a niche product, but kind of look for these patients. They're not going to come in complaining. All these patients here, I kind of noticed the acquired blepharotosis, and just went and got a sample bottle, cut it open, scissors, broke it off, and said, hey, I'm going to put this in here, before and after pictures. And you can see that they're excited with some of these outcomes. So I would just say, try it. And I've actually had patients already have an N of 1, where a patient has said, oh, you fixed my friend's eyelid. I'd like you to do an eye exam, and maybe I could try that on it too. So just be aware of this medication. Tracy, you have any comments on Upneek? I know it's kind of new and kind of out there, but do you have any comments that you want to make before I move into what's coming soon?
So I have a question for you. It looks like kind of a lid lag from a layman's perspective. What like for this young lady, what was exactly causing her issue that it would be improved by Upneek?
Yeah, so it's probably better to me to show you on this one. So where the Mueller muscle comes in into the upper cartilage there, it creates a lid fold. So if you have patients that come in and you look, the lid fold is usually like, I don't know, 2 millimeters above, but this patient's lid fold is pretty high. So that means that the muscle is separating from the cartilage, and that's why they're getting this acquired. The lid lag is more when they look down, the eyelid stays up. We see that in thyroid disease because of scarring, right? The scarring, the inflammation creates it because of the thyroid issue. This here is just kind of a muscle and just separating. You can kind of see it here on this patient. Yes. She has a huge lid fold up here, and that used to be down a little bit. So they're getting this acquired ptosis, and all you're doing with this medication, and you can see here, you can see where her lid fold is, it's way high.
Yeah.
So it's just this, maybe it didn't disinsert, maybe it's just her anatomical variation, but she's thrilled by this. She's like happy as can be. She texted me the other day, thanks for bringing this out. So.
And FYI, it's $4,500 to get your lids, your eyelids raised, because I've had a clinical assessment. As I age, my eyelids start to droop. Maybe I just need Upneek.
There you go. So someone asked about, after installation, do you see an improvement? I see it at about 5 or 15 minutes. If I see I'm going to use it, I run and get a sample, tell the patient what I'm doing, cut the package open, break off, put a drop in. And then by the time I'm done with the exam, that's some of these before and after pictures. That's when I take these, some of them. The other one was when I had to treat the contact dermatitis, but the other 2 patients, that was before and after within the office. So great question.
And how about the other question was, if you, will the Upneek work if you use punctal occlusion to prevent systemic side effects?
The answer is going to be yes. The answer is yes. I'm not sure how much concern I have with this 0.1 creating all these issues. So, but the answer is yes. If you want to do that, absolutely. I'm going to go through these pretty quickly. Then Trace, I'm going to turn over the remote to you. Right. I've been going to CECO. I went to Vision Expo East. I've been meeting with a lot of the companies, and just thought I want you to know what's coming down the pipeline here. These aren't really out yet, but this presbyopia, wait to the end of the year, wait to next year. You're going to be bombarded with people coming in with presbyopia drops. And there's 2 really ways that you do this. It's either through the miotic drops or through lens softening agents that are out there. I just want to show you that there's, I think, 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 drops that are out there. And they're all kind of combinations. You can see miotic, and then using some brimonidine tartrate to prevent the pupil dilation, miotic. And then right here, this is kind of a new one I've been watching through Novartis. It has been owned by a couple other companies. It just keeps getting passed along, but it's a lens softening agent. It actually is going in and breaking up some of the lens adhesions within the eye, returning the accommodation that's out there. So just be aware. Constantly, I'm sitting on ad boards and trying to help when you bring this to market that's out there with these presbyopia drops. And it's going to soon be a crowded landscape where, everyone's going to be jockeying for a position and people are going to be in your office as optometrists. I just want to give you a little bit of a warning of what's coming in the up and coming. And then I thought this was kind of neat, this Demodex blepharitis by Therapeutics by Horizon. We see these collarettes that build up from Demodex. You can see here it's a patho, it's products, it's eggs, it's regurgitated, undigested. Guys, this is a really simple way of putting it. It's Demodex poop. All right. It's what builds up on the lashes. That's all that really is. It's living. It's secreting. It's waste. And that's basically what you're seeing. This is just a nice way of putting it. But there's this TPO3 that's coming, and you can see that it's going to probably be a little bit different. And I like using my tea tree oil in the practice because that's all we have. But it's going to be a multi-dose bottle. It's going to treat Demodex. It paralyzes and puts the Demodex mite to death. It's a twice-a-day dosing for 6 weeks. And so far, it's been showing in the trials that's out there that has a very safe profile. So just wanted to kind of give you a heads up of what's coming. I'm going to let Tracy do some systemic meds, and then maybe we'll have time to quickly go through Oxervate and Tepezza, Trace. So please take it over. I'm going to share you as soon as I can find how to share the remote here.
I will request remote control.
All right, request. All right, there it is. I'm approving you.
Thanks, Greg. So we're just going to go through some of the systemic agents that are out already or coming out on the realm of systemic medication. So I tried to pick some agents. There's so many new ones that come out that are kind of Me Too drugs or those that are truly potentially life-changing. So I wanted to kind of stick with some of our systemic medications that affect the central nervous system or work in the brain. So this Asteris, if you look at it, it says sir-dexmethylphenidate and dexmethylphenidate. I think this is going to be a potentially, very popular amphetamine type combination medication for people with ADHD. And if you look at the first yellow bullet there, it says new oral agent for treatment of ADHD in patients greater than or equal to 6 years and older. So, it's a controversial subject, particularly in very young children, which 6 years old is very young. The American Academy of Pediatrics has very specific guidelines on how to treat children that are that young. And usually it is cognitive behavioral therapy and potentially even nutritional interventions. But it's a new combination medication that structurally is similar to Ritalin. So if you've ever heard of Ritalin, that is methylphenidate. So this has a combination of methylphenidate chemicals. One is sir-dexmethylphenidate and one is dexmethylphenidate. One of them is a prodrug. It's kind of a gimmicky drug, but I believe it's going to be fairly popular in the sense that one of the biggest things that we deal with ADHD medications, which are vital in people that need them, one of the biggest problems that we deal with is kind of how a drug is pharmacokinetically benefiting a patient. So if you have like an immediate release drug that starts working quickly, it shoots up in the patient's bloodstream, suppresses their appetite, increases their heart rate, increases their blood pressure, changes their sleep patterns, works for a little bit of time, and then it's out of their system. Whereas if you switch to a very long-acting medication, sometimes it's not quite as effective because you get blood levels of that drug that's more, static in the sense that it's kind of giving you basal control. So drugs like Vyvanse, drugs like Concerta, drugs like Asteris seek to kind of fill both of those needs. They have a little bit of immediate release acting chemical and then a long acting chemical as well. But keep in mind, this is a Schedule II controlled substance. These are in the same category, the same schedule, according to the DEA, as our opioids: morphine, oxycodone, fentanyl, etc. So they do have the potential to be addictive in patients. I think statistically, personally speaking, in terms of what I see with patients, as well as true data that's out there. People that have ADHD that use these medications appropriately have a very low chance of becoming addicted to the medications, but they are Schedule 2, in the narcotic category. Mechanistically, these are stimulant medications. So they go into that agonist category, just like Greg was talking about the oxymetazoline with the medications, talking about dry eye, red eye, et cetera, the vasoconstrictors that we were just talking about with wasn't lid lag, but the lids that were a little bit farther down. I think he called it ptosis. These are in the same category as that. They're just plugging into different receptors that are part of the sympathetic nervous system. So they are true stimulants. If you've ever heard of the illicit medication crystal methamphetamine, these are babies of crystal methamphetamine. So these block the reuptake of norepinephrine and dopamine in the central nervous system. And the reason why these work in somebody with ADHD or ADD, you have a lot of noise. You go from one task to another. You might study for 5 hours for an exam, and then all of a sudden you forget what you studied for. There are a lot of different signs and symptoms of ADD and ADHD. But it's interesting because these stimulant medications, which you think would make it worse, actually take all the noise in an ADD, ADHD brain and focus the patient. They're very effective. They are almost diagnostic in and of themselves to determine whether or not somebody has ADD, ADHD. The problem is the side effects. Inherently, these drugs are dangerous in any patients that have cardiac abnormalities, either structural or electrical impulse abnormalities or arrhythmias. So you see the typical decreased appetite, increased heart rate, increased blood pressure, increased chance of cardiac arrhythmias, insomnia, addiction, and flat affect. So some people that use these medications might be very animated, and all of a sudden they take the pill and you're like, hello, where did Bob go? Bob's personality is now just flat because they're on this medication. And that's pretty typical. So what Asteris is seeking to do is to, potentially still have these side effects associated with the medication, which they are mandatorily required to list because it is a stimulant medication, but it's decreasing the chance or decreasing the extent of these potential side effects. So I'm, mildly optimistic regarding Asteris, and we'll kind of see what happens. Now, going down the line and looking at the second medication. Oh, this is the advertising for Asteris. And I just want to show you one thing. It's pretty cool. It says it's a brand new prodrug. A prodrug is literally you take a medication, it gets cleaved in the body, usually by either stomach acid or by a liver enzyme, and then all of a sudden it becomes active. So when you actually by mouth take the medication, it's not active. It has to be activated by stomach acid or a liver enzyme. So it says here over on the right, first and only methylphenidate-based prodrug for ADHD. And methylphenidate is kind of the typical Ritalin. So it says proven to address unmet needs. And that's that kind of, quick onset with the fast acting portion, and then it extends you through the day. It's a once a day medication. So it's supposed to have fewer side effects in patients. The next medication that I thought was interesting to mention is Quellbri, which is viloxazine, for ADD, ADHD. Now look at the drug. It's a new type of treatment for ADHD in children 6 to 17 years of age. So prior to being an adult, now we have another drug that is newly indicated and newly approved for people that are kids with ADHD. It is not a stimulant. The only non-stimulant that we currently have that is approved for this group of patients is atomoxetine or Strattera. And that drug is inherently very ineffective. The non-stimulant medications for ADD, ADHD, unfortunately, just in many cases are less effective than placebo. Now, listen to that statement again. In many cases, the non-stimulants like atomoxetine or Strattera are proven to be less effective than placebo. Why the heck would you even want a new medication in this group? Now, this one is a different different mechanism of action than Strattera, atomoxetine, but why would you even want to come out with something like that? Well, what about the categories of patients that cannot take a stimulant medication? Most of the time because their heart can't handle it. So they have a congenital cardiac abnormality or an acquired cardiac abnormality. So this not being a stimulant, it's another one in the group, but it's a different mechanism of action. This is not a controlled substance, so that is a benefit, but to what end? Are we having a non-controlled substance at the expense of efficacy? And that's sometimes what we see. But look at the mechanism of action. This drug is a selective norepinephrine reuptake inhibitor. So that means that using this drug will increase norepinephrine in a patient's bloodstream, which will then increase norepi in the patient's central nervous system in the brain. So theoretically on paper, when I map this out on my napkin at a restaurant, I'm like, oh, it looks good. That's exactly what we want. We want more of that sympathomimetic, that more of that sympathetic chemical in the patient's bloodstream and in their brain. And that's norepinephrine. It does result in higher norepi levels in the brain, which is what we would be looking for. But I have here, remember the SSRIs, the selective serotonin reuptake inhibitors like Prozac and Zoloft? And what about the selective norepinephrine and serotonin reuptake inhibitors like duloxetine or Cymbalta? These drugs are traditionally antidepressants, and they're effective antidepressants. So this one is just a slight change on kind of the typical antidepressants where it's only increasing norepinephrine. So it's a reasonable mechanism of action. We'll see how it pans out. I think it does have the capability of being maybe better efficacy than the atomoxetine, the Strattera, which can only be a good thing. So time will tell. Side effects, look at this list. It can make you tired, or it can make you not tired. Decreased appetite, which is something that we are always worrying about with ADD, ADHD meds. I mean, think about it when you're in a high sympathetic tone. So like the Ritalin, the Adderall, the Vyvanse, the Concerta, et cetera. When you're in high sympathetic tone, it's mimicking your fight or flight or fright. So when you take a typical stimulant, ADD, ADHD medication, your body's in the mode. When you're in the mode, either because you're being chased by Clappy the Clown, you're going to get mugged, you just noticed a giant snake in your backyard. Sorry, Joe, I had to use that one. You are failing an exam, your spouse just told you that you want a divorce, whatever is going to make you nervous and upset and high strung. That's your body saying, we're in an emergency situation. So there are a few things we don't need right now. We do not need to be hungry. We do not need to be thirsty. We do not need to move our bowels, and we do not need to urinate. If you have a full bladder or, a particularly full, I might have to go number 2, you may empty those, the bladder or, excrete, you may have a bowel movement, but in general, the body's turning off those systems. So a decrease in appetite is absolutely perfectly set up for what these drugs are mimicking. These drugs are mimicking the fight or flight or fright. So kids and even adults who take these medications, they're not hungry. So think of crystal meth. You never see an obese crystal methamphetamine addict. They might start out obese, but they don't end up obese because it literally is telling the system, oh my gosh, we're in a terrible scenario here, a life-threatening scenario, even though they're not. So the body is literally saying, okay, we don't need to urinate. We don't need to defecate. We don't need to eat right now because we got bigger fish to fry. And that's what happens with these medications as well. Notice also the suicidal ideation. We know that some antidepressants can increase risk of suicidal ideation. So either a contemplated suicide or a completed suicide, especially in kids and young adults. So that's one of the warnings on the Quellbri as well. But in general, it's a non-stimulant, so it's going to be safer in people with cardiac problems. So the next thing that I just want to show you here is, look at this update. FDA grants accelerated approval for an Alzheimer's drug. An accelerated approval, I mean, we've had more of these types of drugs in the last year since the pandemic started than ever before. An accelerated approval pathway may be used for a drug for a serious or life-threatening illness that provides a meaningful therapeutic advantage over existing treatments. So this is perfect. This medication that you're going to see fits into this accelerated approval category, but it's still got some questions. We still have some questions associated with it. So Aduhelm, it's aducanumab. So you can tell by the name, it's a biologic and it is a monoclonal antibody. So initially when I saw that this was getting accelerated approval by the FDA, I actually texted Greg and said, oh my gosh, have you seen the new biologic for Alzheimer's disease? But the more research I did, the more I realized I'm a little worried about this. So let's kind of page through this here very quickly. First new drug for Alzheimer's disease in almost 20 years. That's wonderful and alarming. It is a monthly intravenous infusion for people who are taking it. And oh, by the way, what this accelerated approval does is it essentially says to the world of patients and practitioners that deal with Alzheimer's disease, we are going to essentially enroll your patients with Alzheimer's disease. We're going to allow them to take the medication, and that will automatically kind of enroll them in ongoing clinical trials, even though this is an approved drug. So we are evaluating the medication as it is approved. And in a few years, we'll decide whether or not we actually want to continue to say that it is an approved treatment for Alzheimer's disease. It's a very, very small category of drugs that could potentially fit this scenario. One of them being COVID, one of them being Alzheimer's disease, one of them maybe being like Ebola, HIV, something like that. So it is a biologic intended to slow cognitive decline in people with mild memory and thinking problems. How do you measure that? How do you say, gosh, I think this drug really worked? I mean, if they hadn't taken the drug, I bet they would have had a faster decline. And that's what we're doing here. So you can see how it would be a difficult scenario to assess clinically, medically, et cetera. It is the first drug that is approved with this, this fast approval category, accelerated approval category, to attack the disease process itself. Everything else that we have for Alzheimer's disease, either from a supplement perspective or a true drug perspective, is literally for mitigation of symptoms. So mechanistically, I'll do this real quick. It targets amyloid, which is a protein that dumps or clumps, excuse me. So it targets amyloid. Amyloid is a protein that ends up in clumps, which makes plaques in patients with Alzheimer's disease in their brain. So we know absolutely that this drug decreases amyloid levels substantially. Here's the rub. We've had other drugs that are anti-amyloid in the past. They were not approved. These were drugs in clinical trials that were anti-amyloid. They decreased amyloid levels in the patient's brain, which ultimately would decrease plaque formation in the patient's brain, and they proved to be non-beneficial. So the folks that are on the, I don't know why you're doing this accelerated approval process for Aduhelm, aducanumab, are saying that what little data we have about anti-amyloid medications is really not impressive at all. So there's a reasonable chance that this drug within a couple of years will fade away. I hope it doesn't. I sure hope it works and that we see great benefit in patients, but only time will tell. And the most concerning side effects for this drug are brain swelling and brain bleeding, which we have seen in some patients. There's only been one death from this side effect so far. Last couple things I'll mention, and then if Greg has anything to kind of wrap it up. Nurtec ODT. ODT stands for oral disintegrating tablet, different than sublingual. And Ubrelvy, notice the names. It's rimegapant and ubrogapant. So they have kind of crazy chemical names. These medications are the first new first new non-triptan, things like Imitrex, Maxalt, etc. The first new migraine, I should say, the first new acute migraine treatment that we've had in a couple of decades as well. And most medications that are in this class of the Nurtec ODT or the Ubrelvy, the calcitone and gene-related peptide receptor antagonists, they're used for prevention of a migraine headache. So if you've seen the commercials, one of the Kardashians, not that I've ever seen the show, but one of the Kardashian girls uses the Nurtec ODT, and she's in the commercial. And it really is an excellent commercial. So people that actually have used Imitrex or Maxalt and either don't do well on it or have too many side effects, et cetera, they are candidates for this calcitonin gene-related peptide receptor antagonist. Or people that use those triptans that don't get as much of a benefit as they should. So I think this is a amazing new category that is going to help patients with migraine. And I know I have multiple patients that are taking these that just can't say enough about them. And in general, they're fairly well tolerated. The last thing that I would mention, kind of keeping with the sympathetic nervous system, is this Gemtesa, this Vibegron. It's a oral beta-3 agonist for overactive bladder. So it's essentially in the same fight or flight or fright, but it's working on beta-3 receptors that sort of envelope or envelop the bladder. So it's telling the bladder to relax. Not as effective as a kind of our old-fashioned overactive bladder medications, but better tolerated. So we'll see more and more of these. So I decided to kind of include these because keeping with kind of the oxymetazoline, et cetera, category of sympathetic medications, and it's kind of an interesting and new set of drugs that we're seeing in patients. Quick question that popped up here. It says, are there any outlines or apps to help with keeping up with new and old meds and their ocular side effects? Oh, that's a good one. I mean, I subscribe to some that I pay for as a pharmacist. I'll have to think about that. And if I can come up with one, I'll have Greg and Joe or Vanessa email you. I can't think of one off the top of my head. Unfortunately, I'm not sure it exists.
I don't really use anything other than Google, for that one. I'm going to take, we started at 7 after. We're right at that hour and 40 minutes. I'm going to take about 3 minutes here and do kind of a really fast version of the ocular biologics here. And just we're going to skip the polling questions and I'll just kind of read them. Which biologic was first used in eye care? Was it Oxervate, Tepezza, Actemra, or Avastin? All these have an ocular indication, and it was the choroidal neovascular, that would be Avastin, that was out there. And you can see that there's been different Avastin or anti-VEGF injections, but the one I wanted to talk about was this Beovu, and it had this 3-month dosing, and everyone was really excited about it. And what happened to it? Why isn't it being used? Trace, I think you got control, so I need that. So you're probably clicking that. All right. So Beovu here, was used for wet macular degeneration, but on April 20th of last year, Novartis announced that completion review, and basically they're getting these strange interocular inflammations that are out there in about 4.6% of the patients. And then some of them are getting vasculitis. Of this 1,098, 36 of them had a vasculitis, artery occlusion, and vision loss of 15 letters or more. So they're really going back and re-looking at this biologic, this anti-VEGF that's out there. So if you heard about a bunch of hype from Novartis, this is the reason. The American Society of Retinal Specialists put out this warning of this inflammation. So you can see it's a low percentage, but it's still a high percentage, enough to create concern, and that's what happened with Beovu. And then which biologic was recently approved for neurotrophic keratitis, and that's Oxervate. And that's actually cool because we as eye docs can use a biologic in a sense, because this is the only one. They're usually very large molecules and they need to be infused, but this one comes in an eye drop form by Dompe, and it's used 6 times a day for 8 weeks, basically every 2 hours. And the key about biologics, a lot different than what we talked about very earlier, is they're very huge, and that's why they need to be infused, but they also need to be grown. And what do they use here to make oxyrvate? Was it E. coli? Was it hamster? COVID-19? Little haha on that, or a Staphylococcus aureus. And they actually use E. coli to make it. And it's used for neurotrophic keratitis. And there's a whole bunch of etiologies out there for neurotrophic keratitis. And there's a classification, stage 1, 2, and 3. And this is truly endogenous neurotrophic keratitis, neurotrophic growth factor. It's true endogenous. It mimics it to help bring back that corneal nerves. And this is what it looks like. It's very complex to some of those other molecules that we were looking at. And that's oxyrvate that's out there. And here's endogenous neurogrowth factor. Here's the Synerginum that's out there, or the oxyrvate. And you can just see here that it just mimics and looks exactly the same. And they're able to basically make endogenous growth factor every 2 hours, 6 times a day for 8 weeks. We're going to skip my patient here. Hopefully that's not going to start. We'll hopefully be able to skip. There we go. And it's, it showed that it does improve neurotrophic keratitis. So it's a drop that you can use out there for your patients with neurotrophic keratitis. And the last one I'm going to kind of blow through here is thyroid eye disease. Thyroid eye disease creates the swelling to these muscles. This came out a little bit too early. This gentleman came in and had thyroid eye disease in 2019. This would have been a great patient to use Tepezza on, or teprotumumab that's out there, which is another biologic, but it needs to be infused. I had to use oral steroids and topical steroids on this patient and use the rheumatologist to treat him. But this is a great patient here. This would have been a patient that you could use, as you can see here, Tepezza or teprotumumab on this patient. And it's by Horizon Therapeutics. It uses a Chinese hamster ovary to make this way here. The insulin-like growth factor is it's a as Tracy said, this MAB, monoclonal antibody. And it attacks the receptor right here. You can see the insulin-like growth factor receptor 1. It competes for this right here. And when you get thyroid eye disease, as this picture is showing you here, both of these receptors are being triggered to create the inflammatory reaction. And what teprotumumab does is it comes in and competes and doesn't allow these two receptors to kind of work hard and synergistically, and it stops the thyroid eye disease. I have an N of 2 patients that this worked beautifully on in stopping their inflammatory orbital disease. So just be aware that Tepezza is out there. I usually work with an endocrinologist or a rheumatologist to get it approved. And then my closest infusion site right now is Pittsburgh, but I'm hoping to get one a little bit closer that's out there. So just wanted to bring it to your attention, oxyrvate, teprotumumab, some of the other medications that are out there. Trace, as I was going and doing that kind of fast version, did any other questions come rolling in?
There was one quick comment that said, patients will come in with a brand new drug and it would be nice to take a quick look and see what to keep an eye out for. So I don't know if that doc is referring to systemic meds or ocular meds, but yes, somebody mentioned Hippocrates as a good resource. Yes, Hippocrates is great. Facts and Comparisons is great. Unfortunately, it's tough. There's nothing that's really acute, very specific synopsis. And then the last person said drugs.com. So maybe we all have to come up with an app that just is like ocular side effects. That'll be in our free time, guys.
There you go. And that will wrap up. And I'll thank everyone for being here tonight. Thanks for coming to Pharmaceutical Update 2021. There's a lot of medications that are out there, and I hope you enjoyed the ones that we picked. Tracy, any comments before I do some housekeeping?
No, thanks for having me.
Yeah, it's great. Always a pleasure to share the virtual podium with you. Joe, any comments before I do housekeeping?
No. I thought it was a very, very informative and very well done presentation.
Thank you. And thanks, everyone.
Thanks, Joe. Yeah, thanks, everybody.